that the NHRC lecture series has been approved for maintenance of certification program from the Royal College of Physicians and Surgeons of Canada. So a few just housekeeping things before we get started. Those of you that are panelists, you can feel free to turn on your microphone and your video throughout the entire session, your microphone when you're asking a question. You can raise your hand if you would like to be recognized, and then you can turn on your audio in order to ask that question. Everybody else, please put your questions into the Q&A, and panelists, if you would like to do that as well, that's totally fine, but it is a little bit more interactive if you actually ask your own questions. We will try to get to as many questions in the Q&A as possible, and sometimes we are unable to get to all of them. So just a reminder of how we'll do this. The first 30 minutes we'll have our speakers give their lecture. Then we'll have a Q&A after that. The final portion of the session is the panelists, all of the hemodynamics trainees will then go into a separate session where there'll be a case-based presentation. We'll give you, the panelists, a link to that session towards the end of this session. And then to everybody, please make sure you fill out the session evaluation. We have made a lot of changes to the curriculum and to kind of the setup of this lecture series based on the feedback that we've gotten through the evaluation. So it really is important for us to hear from you. So please take down the QR code. You can do it now. There will also be a link that will get you into the chat box as well. Let's see. So we already start having questions in the Q&A. That's great. So let me introduce our speakers for today. Stephanie Acosta is a board-certified pediatric cardiologist at the Stead Family Children's Hospital here in Iowa City, where she is also the associate program director for both the cardiology and the neonatal hemodynamics programs. She has a clinical focus on imaging and fetal cardiology and fostering collaboration between multidisciplinary care teams for babies with congenital heart disease. Jose Aldana is a staff neonatologist with a cross appointment in pediatric cardiology at the Hospital for Sick Children in Toronto, Canada. His clinical and research focus is on cardiac hemodynamics and pulmonary hypertension. So I'm looking forward to their talk today and to the discussion afterwards. So all of the panelists, if you can just remember to keep your microphone off until you're actually asking a question, I will turn it over to Dr. Acosta. Thank you, guys.
Thank you. Okay, I'm going to share my screen and get my slides on presenter. Okay, I hope everyone's seeing the main slide. Is that correct?
Yes.
Awesome. Okay, so to start off, thank you for that kind introduction. I'm happy to be able to speak today. I'm going to be talking about anatomic lesions that could be found on TNecho and certain pertinent hemodynamic findings, along with my co-presenter, Jose. And so, no disclosures. This is just an outline to keep myself on track, but the two lesions I was tasked with going over is transposition of the great arteries and then congenitally corrected transposition of the great arteries. And then specifically the pertinent findings or abnormal findings on TNecho would be when you see a right to left atrial level shunt and increased flow velocity across the pulmonary valve. And just to keep everyone open-minded and always keep a broad differential diagnosis as we're going through this talk. So, to start off, I'm going to start off with some echo images. So this is a peristernal long image that I'm showing, and we have two outflow tracts that are rising in parallel, which is clearly abnormal. You should not be able to see both great vessels at the same time in a peristernal long image. And then when we put color over it, this is to evaluate the the valve function, as well as any issues with turbulence or obstruction above the level of the valve, which we do not see. So putting color, we're evaluating the outflow tracts here. This is the morphologic left ventricle, and this is the morphologic right ventricle. So this is just to highlight what we're going to start talking about, which is transposition of the great arteries. This is showing a subcostal sweep 2D color compare. The thing to highlight here is, again, we have a morphologic left ventricle that is giving rise to a great vessel that branches, which is clearly the pulmonary artery. And then the last part of that sweep was to try to show you that the right ventricle is giving rise to the aorta, which I'll try to see if it will play again. Apologize that my slides are having some issues playing. Okay. So moving forward, detransposition of the great arteries, just to highlight, is the second most common cyanotic congenital heart defect. It comes after tetralogy of Fallot. Chromosomal anomalies are rare, and it can be associated with VSD up to 40 to 45% of the time. In addition, 10% of patients with DTGA can also have LVOT obstruction, which is associated with the pulmonary artery. There's a lot of coronary artery variations that can be seen as well, which is important for us as cardiologists to delineate for surgery. This is just a nice schematic showing transposition of the great arteries. It again is a conal truncal abnormality where the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. This results in parallel systemic and pulmonary circulations in which we have deoxygenated blood going back to the body through the aorta, and we have oxygen-rich blood that is being pumped out back to the lungs. This is, again, just more schematic figures to highlight the three main subtypes of transposition of the great arteries that we commonly see. So the first one highlights transposition of the great arteries with no VSD. The ventricular septum is intact. This is a more straightforward case, if you will. Versus in figure B, you can see that there is a significant large VSD that the surgeon will have to address at the time of the arterial switch. And then in figure C, it's highlighting that in addition to a VSD, there also is some pulmonic outflow tract obstruction, which again would have to be addressed at the time of surgery. The pathophysiology in TGA, again, is to highlight you have two parallel circulations. So you're just having ineffective blood flow of oxygen-rich blood not going to the body. It's instead being predominantly sent to the lungs. Same thing with deoxygenated blood. You're having it ineffectively go to the body. You do have ways for there to be mixing, which can occur at the atrial level, ventricular level if there is a VSD, and the PDA. And so hopefully this echo clip, yep, this is playing better. So this is to highlight what we look at when we look at the atrial communication. We're trying to make sure that that laminar color flow is seen and that we're not concerned of any atrial restriction that would lead us to need to go for a balloon atrial septostomy. And this should be a PDA sweep here. This is the aorta and sweeping towards the pulmonary artery. We see the PDA. This is to highlight, again, mixing that can occur at the PDA level. So it's oftentimes you may want to think about it as aorta to the pulmonary artery. So that's your deoxygenated blood from the aorta going to the lungs to get oxygen. And then the oxygen-rich blood from the pulmonary artery going to the aorta is being sent to the body through the shunting we see at this level. So one thing to think about is your effective pulmonary blood flow and your effective systemic blood flow. As a cardiologist, we often think of things as what is our ratio to pulmonary blood to systemic blood. And we do that with a formula that we use very often, especially when we're doing cardiac cases. So we looked at the arterial saturation, subtract the mixed venous saturation, and we divide it from our pulmonary venous saturation. so it's over a pulmonary vein saturation minus your pulmonary artery saturation. And that gives us a ratio of how much blood is going to the lungs versus the systemic blood flow. It is quite difficult to do that in this physiology. And so it's oftentimes hard to medically manage these patients because it's hard to know how much of deoxygenated blood at any moment in time is going into the pulmonary circulation. Same thing with oxygen-rich blood going to the body. But I do just again want to highlight that these are the important levels of shunting that allows for this effective pulmonary blood flow versus effective systemic blood flow. And the most effective mixing is at the atrial level, especially when you're thinking of how do I get oxygen-rich blood to the body. If the atrial communication is small or restrictive, infants will be profoundly cyanotic, and they can also have a slower transition of their pulmonary vascular resistance and be persistently cyanosis even after we do a balloon atrial septostomy. And just to remind everyone, atrial mixing takes place due to the pressure differential between ventricles and diastole. So it is possible that even in the presence of a large non-restrictive atrial communication, the mixing can be insufficient. But we would be proactive to do balloon atrial septostomies as needed to allow a little more stabilization of the infant before they go to surgery. The next thing I would like to highlight is a reverse cyanosis. So that, simply put, is when the right arm saturation is less than the lower extremity saturation. And the two top differentials we want to consider in this physiology is, are you dealing with pulmonary hypertension or an issue with the aorta, being that there's coarctation or interrupted aortic arch. And so this clip is just highlighting that we do echo guidance to do our balloon atrial septostomies. This doesn't show the pulling, but it at least shows the balloon across the atrial septum. And then just to quickly highlight the surgery from our side of things, the standard surgery we now perform on these patients are an arterial switch. So that means that the great vessels are going to be transected above the level of the valve and the coronary arteries. And then the surgeon essentially has to translocate them into the anatomically correct position and reimplant coronary arteries. And this is a cross-sectional imaging CT showing the Lecomte, which is how the surgeon now places the pulmonary arteries. And these are you can see it's not anatomically correct, but it has been found to allow for the coronary arteries to have less compression on them. So there's less coronary artery obstruction that we see since we started doing this. And if it's done well, we will monitor for branch pulmonary artery stenosis that can occur, even if it's done at the best skilled surgeon's level. I just briefly want to highlight some long-term and short-term complications we would watch for. So early mortality can still occur about 2 to 3%. There can be a need for a VSD repair, so that can put the patient at risk for heart block, depending on where the conduction system is and where they put their sutures. As I mentioned before, we worry about the coronary artery reimplantation, so worrying about if there's any kinking or obstruction, which can affect heart function. If you do have outflow obstruction of the pulmonary artery, making sure that the arch is also okay, because sometimes we need to do arch reconstructions if there is coarctation. And then we monitor for any valve issues, of course, and supravalvular stenosis where the sutures were, for where the sections of the cuts were made, and also branch pulmonary artery stenosis. And it's not uncommon that we see neo-aortic root dilation in these patients in follow-up. So that brings me to the next lesion that we're going to talk about. So this is a 4-chamber, apical 4-chamber. And if you see this, you might think, maybe I'm holding the probe wrong. But no, you check and you have the indicator in the correct position. You're now dealing with inverted ventricles. So you should start thinking, are you dealing with congenitally corrected transposition of the great arteries? So this is the morphologic left ventricle. It's smooth walled. There's no attachments of the mitral valve to the ventricular septum. And then if I play this again, you can see how this is the trabeculated right ventricle, moderator band, and you have that offset of the tricuspid valve. So left ventricle is on the right side of the heart. right ventricle is on the left. And then this is basically a sweep in the apical four-chamber showing the outflow tracts. That first one arising here from the left ventricle, and as it continues to play, there's a separate outflow tract arising from the right ventricle, and there's no crossing. So that meets definition of transposition of the great arteries. So in congenitally corrected transposition of the great arteries, you have atrioventricular discordance and ventricular arterial discordance. Essentially, what that comes down to is your morphologic right ventricle becomes your systemic ventricle, which it's not meant for. And so it's at risk of failing throughout the lifetime of the patient that has this defect. Also, commonly, you can have issues with the tricuspid valve having some apically displaced septal attachments, which can then lead to regurgitation. And oftentimes we refer to it as epstenoid. BSD commonly occurs in this, and as well as pulmonary obstruction can occur about 30 to 50% of the time. This again shows some schematics of the different variations that we can see. So this is a straightforward one that shows the usual arrangement and congenitally corrected transposition with an intact ventricular septum versus in figure B, we're seeing a VSD here, and we're seeing some narrowing or hypoplasia of this pulmonary outflow tract, which can cause issues. And then on top of that, you can have mirror image anatomy if you have dextrocardia. And then this is just another way to look at it as far as mirror imaging occurs in the setting of some heart that's laying in a dextrocardic fashion versus levocardiac fashion. And then just to, again, highlight similarly to de-looped transposition, when you have congenitally corrected transposition, you can see that the right atrium is connected to the left ventricle. So that's your first level of discordance corresponding with the left atrium connecting to your right ventricle. But then you also have discordance of the wrong great vessel arising from the ventricle. It does give you correct physiology where you have deoxygenated blood going correctly to the lungs, and you have oxygen-rich blood going correctly to the body. Again, it's your right ventricle is just not meant to be the systemic ventricle. I'm not going to go over this in the greatest detail because it's quite a hot debate in our cardiology and surgical fields, but this is just to highlight some of the ways that we can manage patients that have different varieties of congenitally corrected transposition when we identify it either fatally or in the newborn period. So basically, depending if we see something that's straightforward, meaning we don't see a VSD or outflow tract obstruction, these are the different ways that we could consider managing them, either to just follow them and see how they do versus stage them for a double switch, which involves switching things to do an atrial switch and then a arterial switch, which is a very complex surgery to stage for, and it's still a debate whether that's the correct thing to do for these patients long term. Versus if they have a VSD or outflow tract obstruction that needs to be addressed because that's going to get the baby home, then these are the different avenues of surgery options that we could consider. Versus if there's just a VSD, what are other ways that we can manage these patients? These patients can be identified late, so they can be in their childhood or early adolescence when they are identified, versus they can even be adults. I think with the utility of us doing more echoes, it's happening less often that we're finding adult presentations, but it could still occur. And again, this is just to highlight the different ways that we could surgically think about how we would want to manage these patients. This is just a summary of its ongoing debate among surgeons and centers about what the optimal surgical strategy is, and there's no definitive data to really help clarify which operation is going to offer patients the best short-term outcome and durable long-term solution. And then that brings me to the pertinent hemodynamic findings that I wanted to review. So we're going to talk about a differential way to think about right to left atrial shunts. And then I put this because this is a simplified version for how we try to calculate if there's obstruction across valves, especially the outflow valves. We don't use this for the mitral or tricuspid valve, but we use this for our outflow tracts to determine if we see any gradients that we're concerned about. So it basically is calculating a pressure 4 times the velocity squared is the formula we use in a simplified way. So this is an echo image essentially showing that this baby has mostly right to left shunting across the atrial level. And so already you can start thinking, okay, do I have a normal heart? Not normal heart is one way to kind of broadly think about this finding when you're doing ultrasound or echo of the heart. The 2 top differentials, your heart is likely going to be structurally normal, meaning you have a normal heart, but maybe you see delayed transitioning from the fetal circulation to neonatal circulation, or you're dealing with pulmonary hypertension. So that's kind of thinking of, do you have a normal heart kind of categories versus these last ones listed are, am I dealing with congenital heart defect that I don't want to miss? So the biggest one is total anomalous pulmonary venous connections. Are you dealing with a subset of tricuspid atresia that gives you a hypoplastic right heart? Pulmonary atresia as well can give you a hypoplastic right heart physiology with intact ventricular septum. You can also see critical pulmonary valve stenosis that can give you that right to left atrial level shunting and severe Epstein's anomalies as well. So this is a good way to break down as you're continuing to image to make sure that if you're concerned you're not dealing with the first 2, you get cardiology on board so we can identify if we're dealing with these congenital heart defects. And then I just wanted to kind of give an overview of how we define pulmonary valve stenosis. So we categorize it by mild, moderate, severe, and then the most being critical. Critical means that they need the PDA, so they're prostaglandin dependent. And this is usually due to inadequate antegrade flow across a very tight or small pulmonary valve or annulus. Mild is defined if we see a peak velocity of 2 to 3 meters per second, and that gives you a peak gradient somewhere between 16 and 36. Moderate stenosis is a peak velocity of 3 to 4 meters per second, and that's going to give you a peak gradient between 36 and 64. Severe stenosis is when you have a peak velocity greater than 4 meters per second, and your peak gradient is going to be over 64. I will give a disclaimer that if you have tricuspid valve regurgitation or right ventricular dysfunction, you can underestimate your gradients. And then if you have left to right shunts from a VSD, ASD, or even PDA, that will increase the peak flow velocity. And so it can overestimate your gradient across outflow tracts. This is a peristernal image of the pulmonary valve. And you can see clearly there's aleucine of color and there is turbulent flow. And so when we Doppler it to get that peak velocity, we estimate a gradient of about 70. So by definition, this patient met criteria for severe stenosis. And so they would need to undergo something called a pulmonary valvuloplasty, where they go to the cath lab and we would essentially balloon open the valve to try to relieve that stenosis without creating too much insufficiency or regurgitation of that valve. And with that, that concludes my section of the didactics. And so I'll let Jose take over.
Thanks, Stephanie. Nice presentation. I'm going to share my screen. Daniel, can you let me know if you see it?
Looks like it's coming up.
Okay.
Yep. So just start the presentation.
Do you see the regular main presenter mode?
This is good.
Oh, okay. Sounds good. Thank you. So good afternoon. The part of my session will be focused on coarctation of aorta and TAPVD. And so I'll go ahead and thanks for the invitation. So this is just an introduction slide on coarctation of the aorta, which will be the first lesion that we'll speak about. And I want to transmit, as you probably have seen in your units, that there's a spectrum on how obvious it can be the presentation of the disease, as is shown in the left side, which includes also hypoplasia of the transverse arch. But other times it's much more difficult to see or ascertain the diagnosis, as the example on the right side. And we have to take this into consideration. Sometimes there's just a smaller isthmus, and probably you have had the patient, for example, an ex-preterm infant or a preterm infant with a large duct, with a small isthmus, no clear posterior shelf as is shown in the example of the right, but with the concerning signs of a possible coarctation if the duct closes. So it can be, as it's written here in this slide, it can be a difficult diagnosis and may not be evident in the presence of a large ductus, and keep in mind the associated anomalies. So the key echo findings for, I think, neonatal trainees or neonatologists that are doing echoes is to know the arch anatomy, including how it branches. Doing the sweeps is important, both for sidedness, but also to see the entire length of the arch, the ductus, and then know the profile gradients of that are like seen when there's a severe obstruction in the arch, but also know the caveats of when these flow patterns are disturbed, for example, in the presence of a large duct. And then assess the atrial shunt as well, and intracardiac attention to left-sided structures, because you may be aware that in the coarctation of the aorta might be just one of the components of different left-sided diseases. And then assess for signs of pulmonary hypertension, which can also occur in these patients, and we'll go over the physiology of that. And again, be aware of the common associated anomalies like a bicuspid aortic valve or VSD. And then finally, probably you have already encountered that image as it's shown at the bottom. Imaging at the junction of the isthmus and the proximal descending aorta is sometimes quite challenging, or is quite challenging, and sometimes it's not very well seen the posterior wall of the aortic arch, where we are trying to see the posterior shelf. So it's very difficult. So to begin with the arch anatomy, know that it's divided in 3 segments. Proximal is between the right, the brachiocephalic and the left carotid. Distal arch is between the left carotid and the left subclavian artery. And then the isthmus, which is between the left subclavian and the duct. And then after that is the descending aorta. And as we know that most commonly the coarctation occurs in the isthmus, around the isthmus level, but it can be variable. So also know that, have in mind that variance as is shown here. So typically we see the area of obstruction opposite to the aortic ampulla, but keep in mind that obstruction can be also, it can be variable, including obstruction post-ductal insertion. And also keep in mind that there can be associated transverse arch hypoplasia, which will impact the surgical approach for these patients. Going to the physiology is in cases of severe coarctation, and then remember it's a spectrum, depending on how fast it evolves, the severity of obstruction, the presence of the duct, etc. But in cases of severe coarctation, so the LV will face a rapidly increasing pressure load, which will not allow enough time for the LV to do its compensatory mechanisms, as is seen in cases in children or that have had long-standing like a pressure load, but the LV had time to hypertrophy, etc., and they don't present with shock. So the typical presentation of shock is in neonatal life, because the LV cannot adapt with this rapidly increasing pressure. So the pressure load will lead to increased filling pressures on the left ventricle with increased left ventricular end diastolic pressure, as you see here. And typically, if there's a shunt like a duct, there will be also signs of volume load. As this example show in the slide, there's also presence of here's a VSD, so that will aggravate also volume load to the left-sided structures. And the presence of high filling pressures on the left side, as you see in the example, the end diastolic pressure is 12. That's abnormal. That will impact the LA pressure with potential LA hypertension, and then will build up backward pressure to the pulmonary venous system, leading to edema and pulmonary hypertension. So that's why I was saying it's important on your assessment when you're thinking about left-sided obstructions. It can lead secondary pulmonary hypertension. And then eventually, the LV output will be decreased, the myocardial perfusion will be impaired, and the patient goes into shock. And then keep in mind that the association with VSDs, which is a common association with coarctation of the aortas, will likely cause faster symptoms of congestive heart failure in these patients, because they can really have a bigger impact on the QPQS with a VSD. So here I'll present a case, and Stephanie and me brought a few other cases if there's time to discuss with the trainees. But this patient has basically a classical presentation with shock. At the end, he was already 9 days old, but you can see that he's tachycardic, very tachypneic. He has cyanosis, and he has a differential cyanosis, because the duct was right to left, had some component of right to left at the ductal level. And then he also had a blood pressure gradient between the right arm and a leg blood pressure. You can see that he was acidotic and he had a lactate of 9. So I'm going to play this clip. And as you can see, the obstruction here is evident. And we see the flow acceleration, we see the posterior shelf in the descending aorta or in the isthmus area. Here we do not see the duct. And the last branch that we see from the aortic arch is the left subclavian. So typically in coarctation of the aorta, a thing that you can keep in mind is that the distance between the left carotid and the left subclavian is typically a bit more pronounced. They're more separated. And then you do the continuous wave Doppler. And as you can see here, keep in mind this flow profile, which has a peak velocity and has that persistence of diastolic flow. It's called the serrated pattern. But if you also pay attention to the Doppler, I think you can see in the image, I hope it's transmitting well online, that you are catching two flows. One is low velocity and then the higher one that is the area of the obstruction. The low velocity, because it's a continuous Doppler, you are catching the low flow velocities prior, is because we are getting the flow prior to the obstruction, the velocity prior to the obstruction, and then the peak is at the area of the obstruction. So keep in mind this flow pattern. However, it's important to be aware that these flow patterns are impacted by several factors, like ventricular function. In cases of severe dysfunction, we won't see this flow pattern, depending on the location of the obstruction. If, for example, there's also aortic stenosis, then you don't expect to see this pattern, the severity of the obstruction as well, and then the ductal characteristics. So you can see that there are many other factors that you have to be aware of when interpreting the flow pattern, just as in other evaluations. And then obviously there's the descending aorta flow profile will also be impacted with the diastolic tail, as you can see in the example on the left. And then, as we just said, the ventricular function impacts the flow patterns. And the example on the right is the case of a patient with severely decreased ventricular function, which we see a severely dampened spectral Doppler on the example on the right. Okay, so they went to see the duct, and as you can see here, it's tiny. Can you see my cursor, Daniel?
Yes.
Okay, so I'm pointing out with the cursor of the computer. You can see it's right to left, it's tiny. We see it's juxtaductal, the posterior shell we can see on the posterior wall of the aorta, and then the flow acceleration in that area. And then look at the function and both the tricuspid regurgitation, and you can see that the peak gradient was pretty high. It's reaching more than 4 meters per second, as shown in the left bottom picture. And then the atrial septum, you can see that there's flow acceleration at the atrial septum. And why I show this is because you can have, by measuring the mean gradient from the atrial shunt, you maybe can gauge how an inference on how is the LA pressure. Okay, so we already have this, and probably, as you know, this patient is in shock, in extremis. It's likely you or expected you don't wait to do your full assessment in a patient like this. You already start doing the interventions that are required. Just keep in mind how was the doctor in this patient. So you start obviously with prostaglandins, or if it's the echo lab doing the scan, likely they are already telling you how severe it is. So you start the prostaglandins, and you can see in the example on the left is just 2D, but you can start to see that the duct starts to open and is now bidirectional. But you have a better assessment of how there's also this component of isthmal hypoplasia and likely mildly transverse hypoplasia, but not too severe. Likely this patient will have just a lateral thoracotomy for repair. So just finishing with these lesions, suspect coarctation of the aorta when the PDA is bidirectional, and obviously when you don't have a respiratory cause for that. Typically is right to left in systole. Keep in mind the color and spectral Doppler profile that I already showed from the aortic arch and the abdominal aorta. And also, as you have maybe encountered, mild isthmic narrowing or posterior aortic wall with shelf. It might be difficult to see, but if you have isthmic narrowing, keep in mind and be careful that there could be developing coarctation of the aorta. And then keep in mind the associated anomalies. Going to the next lesion is total anomalous pulmonary venous drainage, and this is the introductory slide. Typically, it's secondary to abnormal development of the common pulmonary vein, which is part of the embryo and fetal development, and persistence of fetal connections to the systemic veins. So that's why I'm saying this, because the evaluation of TAPVD, you have also to carefully assess the systemic veins, SVC, potentially left SVC, etc. Know that it requires a right to left shunt to maintain systemic output, and obstructed TAPVD, as probably you have already seen, is oftenly mistaken with respiratory diseases like PPHN or RDS. On the right, it is I've written the 4 types of TAPVD. The most common one is going to be the supracardiac, and that's the example that we will review. And then we have the cardiac, as is the diagram shown on the upper right, the infracardiac, and the most rare is the mixed one, very difficult one. So going directly to the case, this is a term infant, 2.2 kilos, delivered by C-section for fetal heart rate abnormalities. But shortly after birth, he developed worsening respiratory distress, severe hypoxemia. As you can see in his in the viral stable, saturations of 60, and he went into also shock, cardiovascular collapse. He came to the hospital like basically perimortem or about to arrest. I'm putting in this X-ray just to, again, as a reminder for all of us that these patients, we often get mixed or confused or tricked with respiratory diseases. And actually, this is what this patient went through. Initially managed as respiratory disease, trial of INO, prostaglandins, and then some vasopressors, but didn't respond to the treatment. And I'm going to play this clip. You already can start to think. I'm going to stop it. The complete right to left shunt at the atrial level. I'm going to stop it here because going to go a bit back, because if you're already suspecting veins, I want to point out that don't wait until you get to the crab view to start looking for the veins. I want to point out here, if you see just above the LA, there's a space. That's possibly the confluence of the pulmonary veins that are not draining into the LA. You have to be careful that the pulmonary arteries are some there, but typically they are a bit more superiorly. In this window, you can always Doppler them. You can always doing sweeps, trace them back to the PA if you can do that. But start looking at the veins there since the subcostal, and don't wait till being in the cardiac, in the crab view. All right. We already showed the transshunt, and then you can see massive SVC flow coming into the RA in this patient. Okay, so we already have a suspicion here from this subcostal, and we haven't reached to the crab view. Then as you see on the upper left, it's a tiny clip or small clip, but you can see I'm going to point out that the SVC is very, very dilated. In the middle, we have the aorta, and then on the right side of the screen, we have the PA. Then you see some vessels doing like a confluence, but if on the example on the left upper, we don't see flow on them. I'm going to point out that the scale here is 38. What they did after that is that they dropped the scale to 15, and then you can start seeing flow inside these vessels. These were pulmonary veins going into this confluence, not going into the LA. And I'm just going to show you, correlate this echo picture from the left lower with the CAT image that actually this patient had. Is from the same patient as this patient had a temporizing stent to open up the obstruction at the vertical vein. So you can see that I'm going to point out, we have a right upper in my mouse. I'm pointing it with a cursor in the left lower panel. We have a right lower vein, and then we have a potential single left vein on which I'm pointing in the echo image. But and you can correlate those veins. We mentioned 3, 2 right and 1 left, with the CAD image, which is on your right hand of the screen. And the thing is that the left pulmonary veins, if you see a little bit more distal in the picture, the left pulmonary veins were joining into a common left vein that then drained into the confluence of the pulmonary veins. This confluence, if you follow it superiorly, it goes into that vessel, which is the vertical vein, which you can see that it gets narrowed and obstructed. And I'll show you a bit later the live image. That vertical vein joins into the innominate vein, which then later on joins into the SVC and then drains back into the RA. So that's the pathway of these veins. So I'm going to show you a picture of the obstructed vertical vein that is wanting to drain into the innominate vein. You see very little flow and high velocity for a vein in the pulse wave in the image on the right. And then I'll show you how flow is much better and better, more released once the CAT team did the stent, as shown in this echo window or echo image. Other things that I want to point out with TAPVD is left-sided structures are typically smaller, just because the LV is on their field, not necessarily. Rarely because there's truly left heart disease, because you can see how the right ventricle is dilated, hypertrophied, and pushing into the left side. Okay, and then take a look at the duct. It's a massive, very large duct with also a component of isthmic hypoplasia and possible coarctation of the aorta. And actually, you can see that this arch was being filled retrogradely through the duct, through the flow supplied by the duct. So key echo findings is keep in mind the assessment of systemic venous anatomy, because I showed you an example that goes from the vertical vein to the innominate, but there are variances that can go directly to the right SVC, SVC. Obviously, we have the infracardiac ones. So systemic venous anatomy assessment is important. And as we just said, the lesion requires the obligatory right to left shunt. So the atrial assessment, the size of it is very important. And then when it gets very challenging is the identification of each pulmonary vein and its connection. That's very challenging. And then trying to follow the pathway of the veins or the confluence and where it drains is difficult. Include the 2D color, know the variants of the anatomy in the veins, and again, follow each anomalous vein. And then assess the other things in terms of the impact that it has in hemodynamics. So I'm putting you these two pictures of normal crab view, a normal patient, but compare these ones with these next two. It's difficult. These images that I'm showing you are still images, but we can get tricked that this pulmonary vein confluence is actually the LA. So it's not easy. And I'll show to the trainees if there's time a similar picture live. Which vein confluence sometimes is difficult to distinguish from the LA. You have to sweep sometimes to identify it. But obviously, as the live example I showed you in the echoes, look at the SVC is significantly dilated compared to how it should be. So this is already a clue. And obviously, you would have other clues like the right to left shunt at the atrial level. So very briefly, the physiology of obstructed TAPVDs is, so we have the obligatory right to left shunt at the atrial level with the degree of cyanosis. The degree of obstruction will lead to pulmonary edema and shock. The obstructed pulmonary hypertension, which will lead to RV pressure load, but also RV volume load, because it's a right-sided volume load. And eventually, the significant pulmonary hypertension will lead to RV failure and impairment of LV filling and subsequent shock. So I showed you the echo images, and this is a diagram of the supracardiac TAPVD. Is basically what a patient had on the example that I showed. You can see the confluence of the pulmonary vein behind the LA, draining into the vertical vein, and then the innominate vein going to the SVC. Keep in mind that 40% of these cases with supracardiac TAPVD are obstructed, and I'm showing you here the area of obstruction is when it passes the vertical vein, when it passes between the pulmonary artery and the left bronchi. And I'll just show you here the initial angiography prior to stenting of this patient. Is the same patient from our example, but you can see here in the example on the right, or the image of the right, how after a couple of stents, the flow is, the obstruction is released, and much better pulmonary venous drainage. You can immediately see that. So to finalize, suspect TAPVD when you have a large right to left shunt at the atrial level. When you cannot see the pulmonary veins draining into the LA, start looking at them since the subcostal images. When you have echo space behind the LA, as I pointed out in the subcostal image, where you could start wondering about that above the LA, is when you have small left side structure and dilated right side structures, and always do your pulmonary hypertension and PD assessment. And well, I'm sorry, this is the last one. Take a look at the echo clips from the top. This one, if we just see this one, we could be fooled that this is the veins draining to normal LA. But actually, this is a case of a patient with unobstructed TAPVD, which by doing the sweeps, and obviously here, as I show you in the subcostal, there's right to left shunt at the PFO level. Start looking at the veins in the subcostal windows. The image is not very clear of the LA, but you start to see just above the LA, you see blue flow. If I let it go here, you see my pointer just above the LA. You see some blue flow there. You could wonder if it's PAs, but again, you could Doppler them, and typically they're a bit more superiorly. But follow that blue flow that I'm pointing out with my cursor. You follow it as they continue to sweep, and you can connect that blue blood or blue jet is going superiorly, away from the probe and going superiorly. And actually, if you continue follow that stream, you can actually see how it's getting back into the SVC and back into the array. So the image per se of the crab view, which is shown above, is from the same patient, and it's not the LA. This was not the LA. It's a confluence, and it's shown here in the middle image from the bottom. When they are sweeping, they can show that the pulmonary veins are going into that confluence, which is not the LA. And then that confluence is going superiorly if you follow it, and it's going then later on to connect to the innominate. But again, here the sweep was useful. I think, yeah, that was the last slide, and thank you very much. Thanks, Daniel.